Bueno, buenos días. Es otro día, otra excelente mañana con USPed Latinoamérica, donde estaremos hablando de Vexus, específicamente de su papel en el rol de la determinación de patrones hemodinámicos, de tolerancia a fluidos, etcétera, con el doctor, en este caso, Abhilash Koratala, que es profesor asociado de medicina, director de la clínica de imagen para nefrología de la Colegio Médico de Wisconsin. Es un experto internacional aclamado, del cual nos sentimos muy orgullosos que esté en el día de hoy, y en POCUS, particularmente en el asesoramiento hemodinámico usando técnicas Doppler. Ha desarrollado realmente un currículum en POCUS para residentes de nefrología, publicado en American Journal of Kidney Diseases y Kidney 360. Y también el doctor Koratala es un excelente promotor. Yo diría que el promotor número uno en este caso, teniendo en cuenta sus 31,000 seguidores en Twitter de lo que hacemos en POCUS. Es el más aclamado en este caso de la difusión. Tiene una red extensa, tiene más de 170 publicaciones en journals peer review de amplia gama, y tiene unos excelentes blogs, y es un acérrimo seguidor y difusor de la educación en point of care ultrasound. Yo voy a estar haciendo la doble, en este caso la charla bilingüe, y como les decía, en este caso, it is with great pleasure that we present today's talk from another great Saturday on Focus with USPed Latinoamérica. With us, with great pride, we present Dr. Abhilash Koratala, which is an associate professor of medicine and the director of clinical imaging for nephrology at the Medical College of Wisconsin. He is an internationally acclaimed expert in point-of-care ultrasonography focus, particularly bedside hemodynamic assessment with Doppler techniques. He developed well-structured POCUS curricula for nephrology trainees, published in the American Journal of Kidney Diseases and Kidney 360. In addition, Dr. Koratala promotes POCUS on online platforms such as Twitter. NephroPOCUS, we all heard about NephroPOCUS. Almost everyone who loves POCUS follows NephroPOCUS on Twitter, and also a series of posts for a feature called POCUS and POCU on the Renal Fellow Network, a nephrology blog that partners with the American Society of Nephrology, the ACN. Its online POCUS teaching tool, NephroPOCUS.com, has won the ACN Innovations in Kidney Education Award in 2020. And apart from POCUS, he enjoys all aspects of nephrology and has authored over 170 scientific publications in peer-reviewed journals to date. So, without further introduction, I leave you with Dr. Koratala presentation. At the end of the talk, you can ask our guests today for questions, etc., in a climate of clinical discussion and learning. Okay? Así que sin más, los dejo con la presentación del Dr. Koratala para el día. So, Dr. Abhilash, you can start your presentation, please.
Sounds good. So let me know if you're able to see the full screen, okay? Are you able to see the full screen? Or?
Yeah, it looks all right. Looks okay.
It's not the presenter's mode, right?
No, it looks great. Looks great.
Okay. Okay.
Ready when you are, Doctor.
Excellent. So thank you so much. Thanks for the kind introduction, and also allowing me to be there. It's a pleasure to talk to you all about Vexus, or venous excess Doppler ultrasound. And essentially, Vexus is considered a missing piece of hemodynamic puzzle because we traditionally pay more attention to the parameters of forward flow, such as cardiac output. But recently, venous excess or venous congestion has been recognized, or is being increasingly recognized as a detrimental factor in causing congestive nephropathy. So that's what we'll talk about today. I do not have anything to disclose except that I don't scan children. I'm not a pediatrician. And when assessing a patient's hemodynamics at the bedside, we want to assess three components. One is the forward flow, that is the mean arterial pressure. And is the mean arterial pressure being maintained because of the adequate cardiac output and stroke volume, or is it because of the heart rate and increased peripheral vascular resistance? So we evaluate those things. And when going back in the hemodynamic circuit, we want to assess the effects of the elevated left atrial pressure or left-sided pressures, which manifest in the form of increased extravascular lung water. And when it comes to the right side of the heart, when the right ventricle is not working well, you have increased pressures in the right heart, which are transmitted further backwards to all the organs, causing congestive organ damage. And until now, we had means to assess the extravascular lung water. We used to get chest x-rays all the time. We used to use either ultrasound, echocardiography to determine the cardiac output, and we monitor the mean arterial pressure closely, whether the patient is on the ward or in the ICU. But to measure the backward effects of the right heart, we had limited indices. We were just primarily depending on the inferior vena cava. And recently, Vexus has evolved as an addition to inferior vena cava to assess the effects of elevated right atrial pressure on organ systems. Why do we care about elevated right atrial pressure, or why do we care about venous congestion? Is because, as you know, the organ perfusion pressure is the difference between inflow and outflow. When it comes to kidney, it's the difference between the mean arterial pressure and the central venous pressure, or intra-abdominal pressure when it's elevated. So even if the mean arterial pressure is well preserved, that means the forward flow is good. If the central venous pressure is elevated, that means you're increasing the organ afterload and dropping the organ perfusion. That decreases the renal function, that causes acute kidney injury. So in nephrology practice, we care about both excess fluids and not having any fluid. That is, both volume depletion and venous congestion are important. And as you know, there are pathologic sequelae of fluid overload in almost all the organ systems. For example, in lungs, excess fluid leads to impaired gas exchange, increased work of breathing. In heart, it leads to conduction abnormalities, impaired contractility, and impaired relaxation. In the brain, it leads to impaired cognition and delirium. Maybe some of the ICU delirium we attribute to sedation and stuff could partly be related to fluid overload. And in the liver, it leads to impaired synthetic function and cholestasis. In the gut, fluid overload leads to malabsorption and ileus. In the skin and soft tissues, it leads to poor wound healing and predisposes the patients to pressure ulcers if there is fluid overload. So coming back to Vexus. Vexus is venous excess ultrasound grading system. And in addition to inferior vena cava, it involves assessment of hepatic vein, portal vein, and intrarenal vein using pulsed wave Doppler to assess the blood flow through these veins. And IVC is the first step, and IVC is nothing but, or inferior vena cava is nothing but a tube that goes into the right atrium. So it reflects the right atrial pressure well. I mean, it's not 100% accurate, but for all practical purposes, it's a good enough measure to assess the right atrial pressure. And on ultrasound images, inferior vena cava looks like this. So it's an anechoic tubular structure that goes and joins the right atrium. And here is a hepatic vein joining the inferior vena cava. So with in spontaneously breathing patients with inspiration, the inferior vena cava collapses. So we are looking at both the diameter of the inferior vena cava just behind the hepatic vein IVC junction, and by how much it is collapsing with respiration to assess the right atrial pressure. In adults, it's easy because we take some IVC diameter, such as we take a cutoff of 2.1 centimeters as a normal diameter of the IVC. And we say if it's more than 2.1 centimeters and less than 50% collapsible, it's compatible with a right atrial pressure of 15 millimeters mercury. And if it's less than 2.1 centimeters and more than 50% collapsible, it's compatible with a right atrial pressure of 3. But in children, it's hard because the IVC diameter varies, and you can go by the documented IVC diameters with age, or compare inferior vena cava with aorta in the short axis. These two are acceptable methods in children. And isolated inferior vena cava ultrasound has several pitfalls. For example, in the most of the IVC related literature is evaluating it in the long axis. And as you know, IVC is a cylindrical structure. At least you can imagine that as a cylindrical structure. And you get the maximal diameter only when your ultrasound beam is slicing the vessel in its center. But if the ultrasound beam is slicing the vessel in its periphery like this, then you're going to get falsely low diameter. And that's more important when you are following the patient and you give the patient some fluids or diuretics and you want to follow up on the patient. If one of these measurements falls prey to this cylinder effect, then you get false readings and false conclusions ultimately. And it also depends upon the strength of breath, because you're relying to some extent on the collapsibility of the vessel. So if the person is otherwise strong and able to take a deep breath, then you get good collapsibility. But you have 80-year-old elderly woman, her strength of breath might not be as good as the 30-year-old muscular man. And also, as the patients are getting better during the hospital stay, their strength of breath improves. So it's very hard to rely on either on diameter or on the collapsibility parameters if you are following up on IVC. And also in patients with pulmonary hypertension, whether it's precapillary pulmonary hypertension or because of the left ventricular failure, inferior vena cava could be chronically enlarged in these patients, and it's very hard to make any management decisions just on inferior vena cava alone. And to avoid the cylinder effect, it's always good to evaluate inferior vena cava in its short axis. So here is the anatomic correlate. This is the inferior vena cava here, which is smaller compared to that of aorta and also more elliptical in shape. And in this image, you can see that it's almost completely collapsing with the inspiration. That's how a normal inferior vena cava should be. And here is the anatomic correlate. So this vessel is the IVC, and these are the hepatic veins joining the inferior vena cava. And aorta is somewhere here. And ideally, we should measure the inferior vena cava in both short and long axis, because if you look at this relatively recent study, the correlation between the right atrial pressure and inferior vena cava diameter was good when they took the ratio of the short and long axis diameters. Whereas taking the short axis diameter or the transverse view alone, the correlation was slightly less. And when they used the long axis diameter alone, the correlation was poor. So whatever we've been doing for a long time, just using the long axis diameter of IVC, especially in adult patients, is pretty much error prone. And in this study, they found that the short-long ratio cutoff of 0.69 had a 94% sensitivity and 95% specificity to predict elevated central venous pressure of more than 10 millimeters mercury. So the point is, it's good to measure IVC both in long and short axis. And in general, when you see IVC like this, like elliptical in shape, then IVC is probably not so full. And if the IVC is becoming more and more circular, it's probably indicating high right atrial pressure. And how does the Vexus grading work, and what did the original paper say? So this was the original Vexus study published a couple of years ago. This was actually a post hoc analysis in a cardiac surgery patient cohort. What they found was when these patients had a dilated inferior vena cava that is more than or equal to 2 centimeters, if they had severely abnormal flow patterns using Doppler in one of the, in at least 2 of the veins that we mentioned before, that is 2 of the hepatic, portal, and intrarenal, the risk of development of AKI was substantially high with a hazard ratio of 3.69. So a plethoric IVC and severe Doppler flow abnormalities in at least 2 of the 3 veins predicted acute kidney injury risk. And we know that elevated CVP itself is a risk factor for acute kidney injury. We said kidney perfusion depends upon both central venous pressure and mean arterial pressure. So why should we do additional Doppler studies if you are able to get a central venous pressure reading, or if you are able to just assess the central venous pressure by looking at the inferior vena cava? So they looked at that too. They compared the post-test probability of acute kidney injury when using the severe grade Vexus, that is all the Doppler parameters, and central venous pressure alone, central venous pressure of more than 12. And the post-test probability of having AKI was substantially higher when they took the whole the Vexus grade. So it outperforms isolated inferior vena cava measurements or isolated central venous pressure readings in prediction of organ injury. And how to perform Vexus? We either use a phased array transducer, that is a cardiac probe, or a curvilinear transducer. You can also use a microconvex transducer in children. As you know, the Doppler presets. We have color Doppler, where blue indicates away from the transducer and red indicates flow towards the transducer, assuming you did not invert the scale, of course. And that can be remembered by the mnemonic BOT. And we have pulsed wave Doppler, which we use to assess the hepatic vein, portal vein, and renal parenchymal vein. So when you turn on the pulsed wave Doppler mode, you have a cursor like this with a small opening, and on whatever vessel or whatever spot you place this pulsed wave Doppler opening, or which is called the sample volume or the Doppler gate, that's where you get the velocity measurement using this modality. And when you turn this on, when you start sampling the blood vessel of your interest, you get a graphic representation like this. You have a baseline that represents time, and you have a velocity scale, and positive velocities are represented above the baseline, and negative velocities are represented below the baseline. What do the positive and negative things mean? It just means it's like red on the color Doppler. If the flow is towards the transducer, the waveform is depicted above the baseline. So that's positive velocities. And if the flow is away from the baseline, away from the transducer, it's like blue color on color Doppler. The waveform is depicted below the baseline in the negative velocity range. And always try to use EKG if available. It's just connecting the limb leads, left arm, right arm, and right leg. And EKG will tell you in what phase of cardiac cycle you are in. That really helps a lot when, especially when interpreting hepatic vein waveform. And this is how hepatic vein looks like on ultrasound. This is from the lateral scanning, so from the right upper quadrant. Here you're probably seeing a right hepatic vein or middle hepatic vein entering the inferior vena cava. And most of the blood flow is away from the transducer here. So in general, you expect that the hepatic vein in healthy state is mostly blue in color. And the waveform in pulsed wave Doppler will be depicted below the baseline. And portal vein is a big blood vessel formed by the fusion of superior mesenteric and splenic veins. And it's formed outside of the liver, and it enters the liver and divides into two branches, right and left branches. In general, we sample the main portal vein somewhere here, just as it enters the liver. And coming to the hepatic vein Doppler, so like I said, on color Doppler, it's mostly blue in color because the flow is away from the transducer. And on spectral Doppler or a pulsed wave Doppler, most of the waveform is below the baseline. And there are distinct waveforms within a hepatic vein waveform, and we will talk in detail how they are formed. And with slight probe manipulation, and most of this can be obtained from the right upper quadrant, and with slight probe manipulation, most of the time we should be able to get both hepatic vein and portal vein in a single picture. And hepatic vein is mostly blue and portal vein is red because the blood is flowing towards the transducer into the liver. And here is another nice example. You see a hepatic vein, you see portal vein, and here you get a little bit glimpse of inferior vena cava. And normal hepatic vein waveform. So first we need to picture ourselves like where the vein is and where the blood is going. So here is the hepatic vein, and the blood from the hepatic vein is going into the inferior vena cava and ultimately to the right atrium. So if the right atrial pressure is elevated, you are having more resistance to the flow in the hepatic vein. And here is the transducer. So the blood is flowing away from the transducer. That's why it's blue on color and below the baseline in spectral Doppler. And if the right atrial pressure is elevated, there is back pressure transmitted. So there will be more blood going towards the transducer or towards the hepatic vein. In such case, you will have more of the representation above the baseline. So what are the distinct waveforms within the hepatic vein waveform? We have 4 distinct waveforms: S, V, D, and A. So S means systolic systolic waveform, which is the biggest one. So how is it formed? So during systole, you have this tricuspid annulus, which moves towards the cardiac apex, making more room in the right atrium. That means more blood goes into the right atrium during ventricular systole, or that in other words, there is more venous return during ventricular systole. And towards the end of the systole, as the tricuspid annulus goes back into its position, the right atrial pressure is increased a little bit. So that S wave decreases in size, and sometimes it's below the baseline, or sometimes it can decrease further and go above the baseline a little bit. That's called the V wave. V wave is a transitional wave. It's same as the V wave that you see in the central venous pressure tracing. And during diastole, when there is opening of the tricuspid valve, now there is more room for the blood to flow from right atrium to right ventricle, and eventually there is more venous return going into the right atrium. That gives you the diastolic wave or the D wave. Normally, S wave is bigger than the D wave in amplitude. So that's a normal relationship. And the last wave is the A wave. So after diastole, towards the end of the diastole, you have atrial contraction. The atrium contracts and tries to push remaining blood into the right ventricle. That increases the pressure within the atrium. So you have a little bit small wave, which is A wave above the baseline. Above because the blood is flowing towards the transducer now because it's just a back wave. And here is the hepatic vein EKG correlation. On EKG, you have P wave, QRS complex, and T wave. And hepatic vein waveform is nothing but like a central venous pressure waveform. So the A wave in both central venous pressure waveform and the hepatic vein waveform corresponds to the P wave on the EKG. And the C wave, you may or may not be able to see in the hepatic vein in real life. And S wave corresponds to X descent of CVP. And it occurs right after the R wave of the EKG. And D wave corresponds to Y descent of the CVP, and it occurs after the T wave of the EKG. And able to correlate with the cardiac EKG will make the interpretation much easier. So in normal state, like we said, the S wave is bigger than the D wave. And as the right atrial pressure increases, so that means there is more back pressure going into the hepatic veins, there is more resistance offered to the systolic wave. And you can imagine this situation better when, if you imagine the patient has tricuspid regurgitation. And most patients who are fluid overloaded tend to have some degree of functional tricuspid regurgitation because of the dilatation of tricuspid annulus. And say if you have tricuspid regurgitation or increased pressure during systole, there is regurgitant jet going back into the right atrium during systole. So the S wave becomes smaller and smaller as the right atrial pressure increases. So here S wave becomes smaller in amplitude compared to D wave, where in the normal state, S wave is bigger than the D wave. And you know S wave and D wave just by looking at the QRS complex on the EKG. So the wave that follows the R wave of the EKG is the systolic wave. And eventually, as the pressure increases further, the S wave reverses and sits above the baseline. It goes into the positive velocity spectrum. And eventually, all the waves above the baseline, all this A wave, S wave, and maybe a little bit of V wave, all these things fuse and form one single above the baseline waveform, leaving only the D wave below the baseline. When you see only one wave in each cardiac cycle below the baseline, that's not good. So you call it severely congested hepatic vein pattern, or you can call it a D only pattern because D, or the diastolic wave, is the only wave that's below the baseline, or you can say there is S reversal. So no matter how you describe it, when you see only one wave below the baseline, that's not good. And EKG guidance is very helpful, especially when you have arrhythmia. So for example, in this left waveform here, if you ignore EKG, it feels like there are two waves in each cardiac cycle, right? So we might think like this is S wave and this is D wave. But in reality, when you turn on the EKG, you see that here is the QRS complex and there is no S wave, there is only D wave here. And here is another QRS complex, here is another QRS complex. So in each cardiac cycle, you have only one wave, and that is the diastolic wave. So this patient had severe hepatic vein congestion. On the other hand, in this image here, so if you don't have EKG, it feels like there is one wave above the baseline and one wave below the baseline, one above the baseline and one below the baseline. But in reality, what's happening here is when you turn on the EKG, you can see that there is a wave that is starting in one cardiac cycle and going to the middle of the other cardiac cycle. So that's the fusion between D wave of this cardiac cycle and S wave of this cardiac cycle. So DS fusion usually happens when somebody has atrial fibrillation or just has hyperdynamic hearts with tachycardia, and frequently seen in sepsis or any cause of tachycardia. And how about this waveform here? Is it looking completely normal? I mean, it looks like a textbook picture where this might be A wave, and here is the S wave, and here is the D wave maybe, right? So it looks like S more than D pattern, so which might be a completely normal pattern. But is that really true? We know that only if we look at the EKG. So when I turn on the EKG, you have QRS complex here, and this is the S wave. So the small wave here is the S wave, and this thing is not A wave, but the V wave. And here is the D wave. And usually this pattern also occurs in tachycardic patients, like the D wave of the one cycle fuses with the D wave of the previous cycle fuses with S of the next cycle. So that way we feel that both the fused waves belong to the same cycle. So that should not be confused, and always have EKG. And so in this patient has mild congestion or slightly elevated right atrial pressure, and it's definitely not normal. And hepatic vein waveform exhibits respiratory variation. And during inspiration, you have increased amplitude of both S wave and D wave. And during expiration, you have reduced amplitude of S and D waves, and you may have increased amplitude of above the baseline waveforms, that is A wave and V wave. So in this case, there's a very a case where the patient was breathing very deep. And here is a hepatic vein, and the big thing is the inferior vena cava. Here you see both S and D waves. During inspiration, the amplitude is much higher, and all this thing is during expiration, and the amplitude is much smaller. And coming to the portal vein. So portal vein is different from the hepatic vein because hepatic vein directly joins the inferior vena cava, which is a part of central circulation. On the other hand, portal vein is separated from the central venous circulation by hepatic sinusoids. And that does not allow the complete transmission of the central venous pressure from the right atrium to the portal vein. So you can say that the sinusoids act as resistance sites. And this has been shown a long time ago in this 1987 paper. They show that even when the central venous pressure is as high as 13 millimeters mercury, only about 75 to 80% is transmitted to the sinusoids. And here is a portal, how portal vein looks like from the lateral window, that is the right upper quadrant. Once you put your probe in the right lateral quadrant in the mid-axillary line, once you find the hepatic vein, if you fan the transducer or tilt the transducer slightly anteriorly, you should be able to find the nice portal vein entering into the liver, and you can see it bifurcates into two branches. And inferior vena cava, you will see somewhere here, it will be the oblique axis of the inferior vena cava, oblique to transverse. And from the subxiphoid view also, you can find portal vein like once you find the inferior vena cava, if you fan the probe or angle the transducer slightly towards the patient's right side, then you will find the portal vein entering the liver. Though in real life, most of the time we use the lateral window because it gives less Doppler artifact and has less interference from the bowel gas compared to the subxiphoid window. And here is how portal vein waveform looks like. So in normal scenario, it's pretty much continuous and it's above the baseline. First of all, it's red in color because the flow is towards the transducer. And for the same reason, it's above the baseline because the flow is towards the transducer. And because all of the central venous pressure is not being transmitted to the portal vein, you do not have those distinct SVD waveforms, and it's more or less continuous. It does exhibit some respiratory variation. That is, again, during inspiration, the amplitude increases a little bit, and during expiration, the amplitude reduces. And here is what happens to the portal vein waveform as the right atrial pressure increases. So here is a normal portal vein. The amplitude increases during inspiration and reduces during expiration. And as the right atrial pressure increases, it becomes more and more pulsatile. So normally, the pulsatility is less than 30%. When we are talking about pulsatility, we go into the same cardiac cycle. So I assume this is one cardiac cycle. We mark the highest point and we mark the lowest point. And the difference in between those 2 points in percentage is the pulsatility percentage or pulsatility index or pulsatility fraction. And as the right atrial pressure increases, the vessel becomes more and more pulsatile. Generally, around 30 to 50% is considered to be mildly increased pulsatility. 50%. And so here you can see the difference between this part here and this part here is somewhere between 30 and 50. And as the right atrial pressure increases further, it becomes further pulsatile. Like generally more than 50% pulsatility is considered to be severely abnormal. In patients with further increases in right atrial pressure and typically associated with like severe tricuspid regurgitation, you have this to and fro pattern because you have this wave reversal during late systole. So similar to that of hepatic vein, only the diastolic wave remains above the baseline, and the systolic wave or the late systolic wave reverses and goes below the baseline. That's how portal vein changes with elevated right atrial pressure. And portal vein waveform has some pitfalls. Like hepatic vein waveform, the major pitfall is that without EKG, you can make several mistakes. And also hepatic vein does not always indicate congestion, because in some patients with pulmonary hypertension, you can always have like chronically abnormal hepatic vein waveform. But portal vein is a decent indicator of congestion because of the same logic that it is separated from main circulation by hepatic sinusoids, but it does have some pitfalls related to local pathology. Like if somebody has cirrhosis of the liver, you can have pulsatile portal vein at baseline, probably because it's reflecting more portal hypertension, and there are also little arteriovenous malformations in the area, which leads to hazy flow and also increased pulsatility. Also, sometimes otherwise young and healthy individuals, especially who are thin, can have pulsatile portal vein. So it's not uncommon that during some POCUS workshop, we have healthy volunteers, and some of them might have a dilated inferior vena cava and a pulsatile portal vein. So if they're otherwise, like if the heart is fine and rest of the waveforms look fine, there is no need to worry about it. It's probably because the sinusoidal resistance is not so great in these young individuals, which could be just normal physiology. It's not well studied in younger people and otherwise healthy people. Most of the data we have regarding portal vein pulsatility is from people who have some degree of disease, right? So it's hard to know. And here is a case of cirrhosis. So in cirrhosis, what happens to hepatic vein is that it loses the phasicity. So it does not have like those crisp S and D waves. It tends to flatten out. So it tends to get blunted. And similarly, the portal vein it becomes the opposite. It becomes more and more pulsatile, even if there is no increased right atrial pressure. So that must be taken, we must be aware of that. So in such cases, you might rely more on intrarenal vein or the renal parenchymal vein. So here is an example of completely blue portal vein. Blue means away from the transducer. This patient had severe portal hypertension. So that's why there is continuous waveform, but it's below the baseline. So in this case, you cannot draw any meaningful conclusions regarding the right atrial pressure. It's just altered by local pathology. And the last component is the intrarenal vein or the renal parenchymal vein. When we say intrarenal vein, we are talking about interlobar vessels, which are just beside the medullary pyramid. So medullary pyramids are here, and there are blood vessels beside the medullary pyramids. That's what we are sampling, because that's a renal parenchyma, right? So when you look at the kidney here, in the middle of the kidney, you have all the collecting system and the sinus fat. So this is the parenchyma here. And parenchyma is composed of cortex and medullary pyramids. That's where you want to assess the blood flow to see how the congestion is affecting the kidney parenchyma. And in kidney, in this image here are the interlobar vessels. And you never want to do Vexus assessment in the main renal vein or even in this one of these bigger veins here. So you should go more into the kidney as much as possible. And because these interlobar vessels are so small, most of the time we get both arterial and venous traces together. So arterial trace is above the baseline because the blood flow in the arteries is towards the transducer, right? So your transducer is somewhere here, and the arterial flow is coming towards transducer, so it's above the baseline. And you can clearly see that there is systolic peak followed by diastole, systolic peak followed by diastole, and below the baseline is venous waveform. And intrarenal venous waveform or the renal parenchymal venous waveform is relatively continuous like that of portal vein because it's within the kidney, right? So it's not, and also it's a little farther from the heart compared to hepatic vein. So it does not display the distinct waveforms like that of hepatic vein. And in real life kidney, this is where you would image. So this is a B flow image, and B flow is not available on the machines. In some GE machines, it's available, but it nicely highlights all the vessels. Just to show you the anatomy, I took this picture. So you have this bigger vein and the main renal vein dividing into segmental branches, and ultimately the segmental branches become these interlobar vessels, which turn over the medullary pyramids and become arcuate vessels. And in the middle, there are medullary pyramids. So this is where you would sample the intrarenal vein. And I know that in most critically ill patients, it can be very difficult to find a good Doppler signal. And what happens to intrarenal vein as the right atrial pressure increases? So in the normal state, it's relatively continuous. And as the right atrial pressure increases, you have some dip appearing between the systole and diastole. And then in normal state, there can be a little bit of dip at the end of each cardiac cycle, like this. It's okay, a little bit. And when we're talking about cardiac cycle, the good part about renal vein and the renal vessels is that you have the arterial waveform on the top. So here you don't need to have simultaneous EKG, because the arterial waveform itself is working like a built-in EKG, because you know what is systole and what is diastole. And as the right atrial pressure increases further, you have two distinct waveforms, that is one in systole and one in diastole, one S wave, one D wave. And eventually, like that of hepatic vein, as the right atrial pressure increases further, S wave reverses, and you see only D wave below the baseline. So if you see only diastolic wave below the baseline, that's severe congestion. And the reversed S wave, most of the time you don't see it because it's embedded in the arterial waveform. This is the arterial waveform, and the S wave will be embedded within the arterial waveform, and most of the time it's a little bit small. And if your wall filter is set too high, it might just disappear in your wall filter. And this is the anatomy of the biphasic intrarenal venous waveform. Biphasic is when you see distinct S and D waves like that of hepatic vein, right? So actually, if you remove the arterial waveform, if you can get just the venous waveform, this is how it appears like. It looks exactly same as hepatic vein. So you have S wave, at the end you have V wave, and D wave and A wave. This is exactly same as hepatic vein waveform, which shows that all the circulatory system is in continuity. It's just that because this vein is within the kidney in normal state, it's not exhibiting these waveforms. But as the right atrial pressure increases and that transmits to the renal parenchyma, you start to see these waveforms, which are very similar to that of hepatic vein waveform. And again, like I can't stress this enough, that never forget that you're supposed to sample the main renal veins as much as possible. Go inside the kidney and measure the parenchymal veins, because the main renal vein can be pulsatile at baseline, could just look like hepatic vein in the normal state, and you can think there is too much congestion. It can also happen that the parenchymal vein feels more congestion when you have interstitial edema inside the kidney, and that can actually be more severe compared to the outside vein. So here is a nice example. So this is the kidney here. Kidney image is not that clear, but I mean, so this thing here is the renal parenchyma. But here you are sampling, your sample volume is somewhere here. That's where you are sampling, and you can clearly see there is biphasic pattern. So there is S wave, D wave, A wave, S wave, D wave, A wave, S wave, and D wave. You think it's a biphasic pattern. It's not too severe congestion, maybe it's mild to moderate congestion. But here, when you really sample the intrarenal vein, that is within the renal parenchyma, so this is the parenchyma, right? So, and now you're sampling here, you can see that there is only one wave in each cardiac cycle. Here I have EKG to understand better. So there is only one wave in each cardiac cycle. So that means it's D-only pattern or severe congestion. So you can falsely assume that this patient has mild to moderate congestion if you sample the extra parenchymal veins. And the opposite can happen too. You can also think the patient has pulsatile renal vein. Maybe the intrarenal vein is completely normal and continuous. So always don't forget that you should sample renal parenchymal veins or intrarenal veins and not the main or bigger renal veins. It's a very common mistake done by the Vexus beginners. And so how do we put all of these things together? So how does Vexus grading look like? And in the original study, they took IVC diameter as more than 2 centimeters to be abnormal based on their other previous study related to that in cardiac surgery patients. And generally, if the IVC is small, if it's not plethoric or if it's not dilated and showing a little bit collapsibility, then you can consider there is no congestion, and they graded it as grade 0. But again, you have to take it with a pinch of salt, because not everybody's inferior vena cava size is universal, right? So inferior vena cava size in Ecuador might be different from inferior vena cava size in somebody living in Europe or somebody living in Asia. So those disparities exist. So use your own judgment. And also in children, like I said, it's very hard to go by one particular diameter. You might want to follow some age-related nomogram, or just compare inferior vena cava and aorta in short axis and use your judgment. So obviously we need more studies in children to see what is the ideal IVC diameter that you're using. And this is the transition of these waveforms, just to recollect. In normal state, in the hepatic vein, you have S bigger than the D, and as the right atrial pressure increases, S is less than D, so you call it mildly abnormal. And if the S wave has reversed and goes above the baseline, you call it severely abnormal. In the portal vein, less than 30% pulsatility is normal, 30 to 50% pulsatility is considered mildly abnormal, and more than 50% pulsatility is considered severely abnormal. And intrarenal vein, continuous is normal. If you see distinct systolic and diastolic waves, it's mildly abnormal. And if you see D-only pattern, that's severely abnormal. So how do we grade now? So grading is done only when the IVC is big and plethoric. So a big IVC plus any combination of normal or mildly abnormal patterns. That means any combination of all these 6 patterns, you consider that as grade 1. That means there is no severely abnormal pattern in this. And grade 2, if the IVC is big and at least you have one severely abnormal pattern. So out of these 3 severely abnormal waveforms, even if one is severely abnormal, then you call it grade 2 congestion. And if at least you have 2 severely abnormal waveforms, then you call it grade 3 congestion. That was the degree of congestion that correlated well with acute kidney injury. That way, like performing intrarenal venous waveform is difficult in most cases. So if you're able to demonstrate that there is systolic reversal in the hepatic vein and portal vein is more than 50% pulsatile, you can safely say the patient has grade 3 congestion. You don't even need to do the intrarenal vein. And there is only one study, to my knowledge, in pediatric patients that was published very recently. It was a pilot study in 33 patients, and these were like very young babies, with a median age of 12.2 months, and they used IVC age-related nomogram to determine the size of IVC, and what they found was grade 3 Vexus correlated very well with higher levels of CVP, and so there was exponential increase in the correlation of the grade of Vexus and the degree of elevated central venous pressure. And obviously we need more data in pediatric patients on the size of IVC, and maybe there are some differences between adults and children that we don't know at this time. And also, like, what is the relationship of Vexus to organ injury? Sometimes it can be difficult because compared to adults or middle-aged people, children, like young kids, might have more renal functional reserve, which means their kidney might have better capacity to bounce back to any insults. And you might not see any changes in the creatinine as opposed to adult patients who already have some degree of chronic kidney disease and stuff. But eventually, as these children grow up, their reserve capacity of the kidney comes down and may develop increased susceptibility to acute kidney injuries. So these there are several factors to be taken into consideration, but this kind of studies are a good start. And so before finishing, let's put all these things into like a small case here. This is an adult patient. So this is the elderly woman who has heart failure with reduced ejection fraction. So EF was very low, somewhere around 20, I think. And the baseline serum creatinine was 1.2 to 1.4 milligram per deciliter. And the serum creatinine increased to 2.6, and the sodium reduced to 127. And the admitting doctor thought the patient looked dry, so he held the diuretics. So why did this doctor think the patient is dry? Because this patient did not have any pedal edema. So these were the patient's real legs. That's what we base our decisions on, right? So most of the time we tend to look at the legs, we look at the weight, or documented fluid balance. All of these are error prone. And sometimes we rely so much on JVD, and in some patients we might not be appreciate JVD well. And it's been well recognized that the sensitivity of jugular venous pressure, based by the inspection method, is less than 50%, even in patients with advanced congestive heart failure. So we might be missing a significant number of cases if we solely rely on these traditional parameters. So nephrology was considered for acute kidney injury. So we performed physical examination of the patient. And in our dictionary, physical examination means using POCUS. POCUS is a component of physical examination. So looked at the IVC. IVC looks pretty plethoric. It's big. Even in short axis, it looks round, right? So remember, we said round IVC is not good. In short axis, it indicates elevated right atrial pressure. But somebody might argue that, I mean, maybe this patient has, chronically dilated IVC or pulmonary hypertension. So now we do Vexus. So here is the hepatic vein waveform. Here you can see only one wave below the baseline in each cardiac cycle. And there is a reversal of S wave here. So this is severe congestion. And in the portal vein, it's 100% pulsatile. And also there is a little bit of below the baseline component. So this is severe congestion too. And here the renal vein, we obtained without the arterial tracing here. So you have only D wave below the baseline. This thing is the S reversal above the baseline. And D wave here, D wave here. So overall, this is Vexus grade 3. All the 3 components are severely abnormal. So the recommendation given by the nephrology team is that do not hold diuretics, because this patient is having AKI because of congestion. This is not AKI because of volume depletion. So the IV diuretics were restarted. And now we'll see like how this changed. So these images were obtained using a handheld ultrasound device. And the rest of the images I'm going to show are obtained with my bigger machine, which has EKG capability too. So this was on the first day, on the same day as the previous images. So hepatic, you see D only pattern because after this QRS complex in the EKG, the wave you see is the reversed wave, which means S wave or the systolic wave has reversed. You have only D wave below the baseline. And portal vein, 100% pulsatory with flow reversal, intrarenal vein, again, D only. So we said AP is assessment and plan. So we said severe congestion, start intravenous diuretic. And we said intravenous because when the portal vein is pulsatile, it might indicate gut edema. So the absorption of oral diuretics might not be that great when somebody has gut congestion. And on the follow-up exam, the serum sodium has improved to 132 from 127 initially. And the creatinine has come down from 2.6 to 2. That's great improvement. But again, like we have to see how the congestion is improving, right? So hepatic vein, we looked at it, it almost looks the same, maybe a little bit of S wave trying to come below the baseline, but other than that, it's pretty abnormal. And the portal vein is still 100% pulsatile, and the renal vein is D only pattern. In this image, you can see the arterial waveform above the baseline, and you can clearly note that there is D only pattern. So even if the creatinine is improving now, we recommended that continue IV diuretic or the intravenous diuretic because the portal vein is persistently pulsatile. So your diuretic absorption wouldn't be that great. And on further follow-up, now the sodium has improved to 135, creatinine came down to 1.7. And interestingly, now the S wave, both S wave and D wave were below the baseline. Here is the QRS complex. You can see that in each cardiac cycle, there are two waves. It's just that S wave is slightly smaller than the D wave. It's mildly abnormal, but almost normal, like very close to normal. And portal vein is pretty normal now. The portal vein congestion has completely resolved. And the renal vein usually lags behind because there is interstitial edema, even if your overall central venous pressure has improved. So but still it's a good improvement. You see both systolic and diastolic waves below the baseline because in the previous pattern, there was only a D only pattern, right? Only D wave below the baseline. Here you have both systolic and diastolic waves below the baseline. So because the portal vein has normalized, we said it's okay to transition to oral diuretic. And there is no need for IV because the gut congestion probably has resolved. And on further follow-up, the sodium has normalized to 137, creatinine has normalized to 1.5. I mean, it's not normal, but that's our patient's baseline. As you remember, the patient's baseline was 1.2 to 1.5. And the hepatic vein waveform is completely normal here, S more than D. Portal vein remain normal. And renal vein still, like it has both S wave and D wave below the baseline. But again, like that's the last one to recover. So in general, the portal vein is the first one to improve, and the intrarenal vein is the last one to improve. So this is a case which nicely summarizes how we use Vexus in our practice to diagnose congestive nephropathy, that is AKI due to venous congestion, and how we use it to follow the efficacy of your decongestion therapy, follow the efficacy of whatever treatment you are giving, whether you are giving diuretics or ultrafiltration. So it helps both ways, both for diagnosis and monitoring. So that's it for now. Hope I was able to convey most of the concepts that are important. So thank you so much.
Thank you, Dr. Koratala, for your presentation. It was a masterclass. Everyone on the chat is just giving you congratulations for the conference. Thank you so much. Yeah. From Venezuela, from Mexico, from Ecuador, from Argentina. This is a very wide group in Latin America, and we have several questions for you. We're going to bump you. We're going to bump you with questions.
Yeah, let's see if I know anything.
Yeah, I think you know. So we have a question from Joaquin Martinez. He's an ultrasound performer from Venezuela. You must know him from Twitter. He's always very...
oh, yeah.
You know Joaquin. He's very eager on Twitter.
He always tags us. He shares some papers every day, right?
Yeah. He's always sharing. So Joaquin says, what do you think about the use of Vexus protocol in primary care or clinic for the diagnosis and referral of patients to some specialized centers in case of venous congestion?
Well, I think it's definitely a great idea and it's feasible. I mean, I don't do primary care, but I do nephrology clinic. So I use Vexus in the clinic. It takes little time. Maybe you need like a 10 minutes additional time per patient. But again, you can use that time to take history from the patient and talk to the patient and explain what's happening to the patient. So it's not really a waste of time as most people think. And I think it's realistic because I do it in nephrology clinic, and it's a good idea to assess the congestion. And if you find significant congestion that warrants hospital admission or specialty referral, you can definitely use that. But the caveat I would imagine is that you are good with Vexus, you do it, you know how to interpret that. But when you refer to the specialist, maybe a cardiologist or somebody, a nephrologist, they don't know anything about Vexus. So then it's going to create some discrepancy, and they might not be able to utilize the information that you obtained, or they might not be able to understand what your real concern is, right? So they might still be looking at pedal edema, or they might be looking at the JVD, which they can't appreciate. And they say, this patient is feeling fine, and I don't know why this primary care doctor referred to me. So I see that's the problem. But other than that, technically, I think it's feasible and it's a great idea. And eventually, that's what would happen in primary care.
Yes, because Vexus still needs to be needs more widespread internationally.
Yeah.
Needs to be more guidelines. Needs to be more like a methodology to approach patients. Because as Joaquin says on the question, right now the papers are about the critical patients, the patients with heart failure, the patients with the post-ops of cardiac surgery. But in the future, maybe a screening tool for patients on the clinic to referral.
Yeah, absolutely.
To be referred to, of course, to a specialist who knows about Vexus.
Absolutely. And yeah, and the data is expanding. I mean, the original study was in cardiac surgery patient, but
yeah.
After that we had some in general ICU cohort and in heart failure patients and so on, even on floor patients. And we had several case reports in hyponatremia and also in nephrology, congestive nephropathy. So yeah, that's great. It's improving.
Like the paper of the approach of hyponatremia with Vexus.
Yeah, we had several case reports and we summarized that. Yeah.
There's another question from David Pascual Rojas Flores, which is a big consultant from Mexico. He first congratulate for the conference. He says, excellent lecture, Professor. 2 questions. Where to see the future of Vexus in critical care patients? And the other question, have reached the pinnacle in reducing / stopping excessive fluid use?
So I did not understand the second part. Can you repeat the second part of the question?
If the Vexus have reached the pinnacle in reducing / stopping excessive fluid use, like the pinnacle of the monitoring tool, have been reached by Vexus so far?
Yeah, I mean, I guess like the future. I mean, the future is bright because more and more people are getting interested in Vexus, right? So people from all different countries. Especially in the critical care, the use is rising. And we have to see Vexus only as one part of the hemodynamic circuit. Obviously, there are other important parts where you want to monitor the cardiac output. It's very important. You want to look at the lungs, which is very important. And coming to Vexus, it's only one part because Philip Rolla and all these, the original crew has brought up the Eduardo Arguez, and all these people have brought up the concept of fluid tolerance now. So even if you have wet lungs, you should think twice about why this patient should get fluid. So in that sense, Vexus as a part of the hemodynamic puzzle or as a part of the hemodynamic circuit, I think the future is bright and eventually everybody will use. Once you see a plethoric IVC, once you have suspicion for organ injury from congestion, I think it will become universal. And regarding the fluids, yeah, I think the recent paper in NEJM you probably saw in acute pancreatitis, like too much fluids are going to cause harm. So we need more and more data on in different scenarios. And as we realize the effects of excessive fluid administration, I think Vexus will be a great way to avoid it. And maybe in the future, we might not even need to use so much Vexus to diagnose, but more to monitor, because we are trying to avoid iatrogenic fluid excess. I mean, there are two studies in NIGEM, right? One thing was very recent, like I think a couple of days ago in pancreatitis patients, which showed harm from the fluids. And there was, I think, a couple of months ago, there was a study in septic patients where they looked at restricted fluid strategy versus liberal fluid strategy, but they did not find advantage of one over the other. But at least that study established that restrictive fluid strategy is safe. It's not going to harm the patients just because you're restricting the fluid. So we need more data. And also that study has used less fluids even in the liberal group compared to the previous studies that showed harm. Like previous studies that showed harm, they had a fluid balance of like positive 6 liters, 8 liters, something like that. And this study was very little. I think it was, the difference between the groups was very little, like 1 to 2 liters. So that's why it's failed to show the difference. But the great part is that the restrictive fluid strategy did not hurt the patients. So yeah, as we realize more of this about the fluids, and I think we'll reach where almost all the physicians use Vexus. It shouldn't be really confined to ICU alone. And yeah, as Joaquin said, like in primary care practice or even nephrology practice, it should be a standard. But again, as a one component, we shouldn't be paying like too much attention to that, like and forget everything, right? Sometimes in excitement, when we get a new thing, we focus only on Vexus and we forget about other things. That should not happen.
Yeah, excellent. So I have another question. It says the applicability of Vexus on mechanical ventilation and some considerations on poorest nutrition patients of low-weight patients.
So in mechanical ventilation, it's the original study had several patients on mechanical ventilation because it was a cardiac surgery patient cohort. The paper does not exactly say like how many people are on mechanical ventilation. I just know that many of them are, talking to this Philip Rolla, Corbin, and some of the original authors. But what the subgroup, there's a table in the original study. In the subgroup analysis, they say that the portal vein pulsatility was higher in people who were intubated compared to those who are not. But the point is, patients who remain intubated after cardiac surgery probably have more critical illness or more severity of the illness compared to people who were not intubated or who were able to be extubated right after the surgery. So the first point is that, yeah, it's definitely valid in mechanically ventilated patients. And they faithfully, all these parameters reflect right atrial pressure severity or the congestion severity, assuming you know the limitations. Like hepatic vein, you don't interpret without EKG. Portal vein, you pay attention to thin individuals and maybe the cirrhosis patients. And intrarenal vein, if we don't know how chronic kidney disease affects these waveforms. So we should be aware of all these limitations and interpret with caution. So just don't interpret portal vein pulsatility, but obviously look at the right heart also, see how the right heart is moving or whether it's dilated if you have tricuspid regurgitation. So it's always a combined assessment and not isolated. And the second part was in thin individuals, was it like, or malnourished individuals?
Yeah, thin individuals, malnourished.
I don't know about malnourished individuals. I've seen like very thin patients in ICU, but I don't know specifically if there is any like concern in specific cases of malnourishment that I don't know.
But I have
seen very thin people though, yeah.
So in very thin people, then any considerations?
Sorry.
In very thin people, considerations about regarding the different persons can be modified by the skinny people.
Yeah, we don't know. Apart from the portal vein pulsatility in otherwise healthy people, we don't have like specific data on like thin individuals. So we don't know. I would assume that yeah, again, same thing, like we look at the whole picture and are they sick? How is the right ventricle, and go from there. Because all these things are determined by the health of the right ventricle, right? If you are showing that the right ventricle is doing very well by most of the parameters, you look at the TOPSy or tricuspid S prime, tricuspid regurgitation, right ventricular systolic pressure, and right ventricular dilatation. So if all these things are normal, and then if the portal vein is abnormal or something, even the intrarenal vein is abnormal, then you would think probably it's a false positive thing. But in general, the false positives are pretty low.
Yeah, I haven't read papers about comparison the Vexus on mechanical ventilations regarding to the influence of thoracic pressure to translated to intra-abdominal pressure and affecting the patterns. Do you have any concerns about it?
I don't think it's
like a specific settings from ventilators and can modify patterns as well. The same we know that can be modified. For example, the IVC is screening.
Right. So yeah, it's true that the IVC doesn't exactly reflect the central venous pressure, but in general, if the increased intrathoracic pressure is modifying the venous waveforms, that means it's altering the flow. That's whatever might be the cause, whether it's pressure overload because of pulmonary embolism or pulmonary hypertension, or iatrogenic pressure overload because of mechanical ventilation settings, or volume overload, or a combination of all these things in critically ill patients. If the blood flow is altered at the organ level, it must be injuring the organs, right? Even before Vexus, we know that people on mechanical ventilation tend to have increased incidence of acute kidney injury. We just don't know if it was because of the pressure alone, or again, like these patients are sick and there are multiple factors causing acute kidney injury. So this is the time to study more what is the effect of these individual parameters. But in general, just the settings of mechanical ventilation itself should not unvalidate or disqualify the Vexus score if it's severe. So the severe Vexus score is still indicating altered blood flow at the organ level or congestive organ injury.
And mainly because our critical patients are on mechanical ventilation, so we have to adapt.
Yeah.
We have another question. Any recommendations on patients on overload which are on dialysis where the kidneys can be hypertrophic and difficult to evaluate intrarenal vessels with Doppler?
Yeah, so you're talking about end-stage kidney disease patients who are on dialysis, right? So who are on maintenance dialysis. In those patients, we don't use kidneys at all. I mean, I never do kidneys because we really don't know how these waveforms behave in advanced CKD. I've seen several patients with who are not on dialysis, like chronic kidney disease stage 4 and 5, who come to the clinic. They tend to have baseline abnormal waveforms, though their IVC is completely small and collapsible. Their hepatic vein waveform is normal, but the intrarenal waveform tends to be abnormal in some patients, like a chronically biphasic pattern. So again, after CKD stage 3, we really don't know how these behave in chronic kidney disease, and end-stage kidney disease is totally, I think it's not worth doing it. So I would just go by the hepatic vein and portal vein and in end stage disease. I published a couple of cases where I just used a portal vein. Even in patients with severe pulmonary hypertension, portal vein tends to get better after dialysis. It's a very good marker. You can dynamically see, like there was one case where how portal vein was pulsatile, and pulsatility reduces in the middle of dialysis if you're removing good amount of fluid. But if the patient is otherwise fluid overloaded, like if you do a Vexus scan, like 2 hours, 3 hours after dialysis, the portal vein again becomes pulsatile. So it's important that you consider portal vein pulsatility before dialysis and few hours after dialysis, and not just rely on repeat portal vein just immediately after dialysis or midway during dialysis. That might just get like normalized. But yes, the point is you can use hepatic vein and portal vein. I don't think intrarenal vein should be used in dialysis patients. But if your patient has cirrhosis or something, then you can use other veins such as femoral vein, for example. If you have EKG, interpreting femoral vein is also much easier, and femoral vein can be easily accessed. And sometimes I try to use, go to suprasternal notch and image the superior vena cava if possible. You can access superior vena cava from even the subxiphoid, so the subxiphoid bicaval view. You can get a tracing from there unless the patient has distended abdomen. So I use either suprasternal window or femoral vein in some cases where it's ambiguous, where the liver is diseased.
Now you're talking about femoral vein. What do you think about a femoral vein as an extended Vexus?
Yeah, I think it's a great opportunity for people in acute settings like you, like critical care physicians or emergency physicians, because most of the time they are placing lines and they can do it pretty quickly, and it's very easy, like very easy to find. But again, the one problem with femoral vein is that you still need EKG. Without EKG, it's very hard to figure out like what waves are you looking at. You can say it's pulsatile or not pulsatile. You can just go by some assumption that you don't want to see most of the above the baseline waveform like that of hepatic vein. And it's studied in limited scenarios. So, but I think hopefully it will be studied more.
Yeah, we recently sent a paper on extended Vexus using femoral vein on a newborn, a septic newborn. We sent it to the POCUS journal, so when it's out, you can read it and tell us what you think about it.
Oh, that's great. Yeah. It's great. In newborn, it's even more interesting. Yeah,
interesting. There's a paper in 2010, so like 10 years approximately from the first Vexus definition, which is from Huta, a doctor who creates a score to determine the heart failure in the fetus. And if you take a look at the paper, it's a prelapse of a Vexus score. So he uses, in this case, he uses the ductus and another setups of veins to Doppler, but it's a nice precursor. I will send you
sure,
to take a look at the paper to tell me what you think about. So I have a special question because a few days back I was in a POCUS like a workshop, a POCUS workshop, and some expert says that probably in the coming days or months or probably years, the IVC should be removable from the Vexus score. What do you think about?
I don't know. I mean, I'm not an IVC hater. The problem with the IVC is that throughout most of the critical care literature, wrong questions have been asked to IVC. So I think IVC is a decent indicator of right atrial pressure, and you ask that question and you answer, that's it. But previously we were asking questions like fluid responsiveness just based on the IVC or the indication for fluid administration because of the IVC. Those are all wrong questions, and we learned over time that they are not good. So in that sense, yeah, most people developed some degree of hatred towards IVC, that they say IVC is useless parameter. But I think it's in terms of Vexus scoring itself. So IVC is the first thing to get affected by the right atrial pressure, right? So one thing
it was referring to go directly to hepatic, directly to portal, directly to the renal, and do not answer the IVC.
I mean, you can do that, but again, like, what if the IVC is small and collapsible? Then even if your other waveforms are abnormal, then you have to think about it, because there are several. So hepatic vein can be, let's see a situation where IVC is small and collapsible, but you have a little higher grade Vexus. So assume IVC is small and collapsible, but you can have hepatic vein S less than D pattern if you have atrial fibrillation, right? So that reduce, because your S wave is partly dependent on atrial relaxation. So your S wave can be small, and even in some severe cases of atrial fibrillation, you can have like almost disappearance of S wave. And or some people have like chronic RV dysfunction, I mean, relatively compensated, but if the tricuspid annulus is not moving as much or your top C has reduced, then your S wave will be smaller. It does not mean the patient is fluid overloaded. And portal vein, it's hard to interpret in patients who have liver disease. And intrarenal vein, it's hard to interpret in patients who have chronic kidney disease. So yeah, it's always good to have some sense of like what's happening to the vein that is directly in contact with the right atrium. Whether you want to look at inferior vena cava, it's fine, or you don't like IVC, you like internal jugular vein, that's fine too. So whatever vein. So, but because both these veins are in almost direct contact with the right atrium, so I don't think it will be completely eliminated, but we probably will move from like too much concrete belief that IVC should be 2 centimeters or IVC should be 2.1 centimeters to do Vexus.
Yeah.
We'll probably move away from that concept for sure, because that 2 or 2.1 cutoff is not applicable to everybody. Yeah.
Yes, of course, and because I still think that IBC is a great tool for monitoring, because it's the first great Stalin resistor that we start to do in research. So it's the most investigated parameter of the ultrasound, probably of the POCUS. They started with the estimation of the radiator ratio, the fluid responsiveness, etc., and they incorporated into fluid tolerance. But when you investigate a parameter so much, then you start to determine the pitfalls.
Yeah, absolutely.
That's still a great monitoring tool. So regarding children, we have. I know you're not a pediatrician and you don't examine children, but we have some concerns. The concerns are starting from the IBT, the diameter. The paper that you posted on the conference is an excellent paper. We discussed it on a group because it was the first paper that approached the Vexus on children, and they used the Katuria paper. That was a paper from a couple of years ago that studied children using indexed body surface area to determine the diameters. So yeah, we use another cohort and we investigated using collapsibility. I know that collapsibility can be hated because if you have some percent of collapsibility, then maybe the patient it's tolerant to fluid. So the percentage of collapsibility of IVC, for example, 21, 22, 23, 24 of collapsibility doesn't give you an approach of patient tolerance. So that's why, and on Vexus, they use diameter. So that's the first concern, because when you approach hepatic, when you approach pulsar, when you have, it's the same in children. It's the same. So the first concern is that we can use, what do you think about using diameter or using low percentage of collapsibility in children? When I mean diameter, yeah. I mean diameter indexed to body surface area. Right.
So yeah, I think it's diameter is the better parameter when you compare diameter versus collapsibility. I mean, nothing is perfect, neither diameter nor collapsibility. But again, in children, how do we even like assess collapsibility? I don't know. Like if you have a 1-year-old child, like you can't ask them to like breathe and collapsibility is also like, it's not really for critically ill patients. It's this was like more than 50% or less than 50% was made more for the outpatient echocardiography laboratory to make things easier, to make the reporting easier. That way they just ask the patient to take a sniff and measure the collapsibility there. But in the critical care settings, I don't think it was ever really validated and used. So I think for now, diameter is a good way. And I don't know what you feel about comparing the IVC aorta diameter. I see that a lot in the pediatric literature, especially in a little bit of kidney-related literature. They say like dehydration correlates with IVC aorta ratio of less than 0.8 and stuff. Maybe that's another practical way to do it. Though I never do it in others.
Yeah, we're going to include it in the next research, because the first research we did was using collapsibility and the other parameters from Vexus. Then we start to incorporate the diameter indexes by the Katuria indexes. By the Katuria index, it was made on clinical children, so clinical children without any disease, or non-critical children. So we're starting it's still the pediatric Vexus still has a long way to determine something. So we started with that paper that you presented on the conference, and we're going to do some papers to create a proper pediatric Vexus definition. That's what we're doing right now. We're working on it.
Absolutely. And also there might be some regional variations, right? So, I mean, an American paper taking these nomograms might be different from South American paper.
So imagine the creation of the paper itself with all the charts by age, by body surface area. All the indexing is more complex.
Yeah.
Because from more than 1 month to less than 18 years, it's a wide angle to determine. But in regarding hepatic, regarding portal, regarding renal, it's the same. It's just how to make the methodology. So we have other questions about tricuspid regurgitation considerations. You talked some about it, but this is a question from Dr. Kin Siu from Venezuela. It's some considerations about tricuspid.
So tricuspid regurgitation, two things, right? One is the patient, does the patient have structural tricuspid regurgitation to begin with? Then hepatic vein systolic wave is always reversed. But still, the point is, if the portal vein is pulsatile and the intrarenal vein is also pulsatile, no matter what is the cause, whether it's tricuspid regurgitation from pulmonary hypertension or functional tricuspid regurgitation from fluid overload and pressure overload, or a structural tricuspid regurgitation because of the problem with the valve itself, if the kidney is feeling the congestion, it's feeling the congestion. So it's the congestive organ injury doesn't discriminate between what is the etiology. So it's us who should determine the treatment based on the potential etiology. And in our experience, we saw that in most of the time, even if the patient has tricuspid regurgitation, at least even if the patient has severe tricuspid regurgitation, the portal vein can get relatively normal, if not completely normal, say at least like 30 to 50% somewhere. It's very unlikely that a patient has like completely to and fro portal vein or 100% portal vein just because the patient has severe tricuspid regurgitation. And we also see that in functional tricuspid regurgitation, we always see that the patient has moderate to severe TR qualitatively. When we begin the examination, when the patient is Vexus 3, you give them the diuretics, you do ultrafiltration. In 4 to 5 days, the tricuspid regurgitation becomes small or trace. The point is that even if there is tricuspid regurgitation, if there is increased Vexus grade, it should be considered detrimental to organ function. There is evidence in patients with pulmonary hypertension who are undergoing a right heart cath. They did a study just using the intrarenal vein, and the monophasic pattern and more of the cardiac cycle without the waveform flow, they labeled it as renal venous stasis index. So that correlated with the mortality and worse outcome. So pressure or flow problem or volume overload problem, if the organ is feeling congestion, it is feeling congestion. But in general, we use portal vein as a guide in patients who have chronic tricuspid regurgitation. I recently published a case in a dialysis patient who had pulsatile portal vein before he has chronic severe pulmonary hypertension, and after dialysis, the portal vein has completely normalized. Yeah, we see that occasionally.
Excellent. So we have a final question because we're going to be bumping you all day and all afternoon, and this is going to be for a long time because Vexus, we love Vexus, we love focus, and we are able to talk 24 hours about focus. So right now, the last question will be when Rola, will be Soligny, with Kuro, other guys, all these guys started, they talk about Vexus as a tool. Even someone is asking if Vexus can be used to determine fluid responsiveness, although we know that I made a parenthesis, although we know it's fluid tolerance and tube removal tool. What do you think about it? Can be still used to determine fluid responsiveness?
I don't think so. So Vexus is nothing but an extension of inferior vena cava, right? So if inferior vena cava cannot be used to assess fluid responsiveness, this cannot be too. So the point is, like, to assess fluid responsiveness, the best way, first of all, we don't know what is the use of defining fluid responsiveness, because exhausting fluid responsiveness is never the goal of therapy. That's the first thing, because in this patient is fluid responsive. I don't know, it does not mean it's indication to give fluids. But once you know that, to know that you really want to give a small fluid bolus or raise the patient's legs and determine the stroke volume before and after that, that's the best way to determine fluid responsiveness. And when it comes to right-sided parameters, inferior vena cava, or for that matter, Vexus, is only telling you about right atrial pressure. Or you can use right atrial pressure as a surrogate for preload. When you look at the Frank-Starling curve, like preload on the x-axis and the cardiac output on the y-axis, just by knowing an absolute value of preload doesn't predict volume responsiveness. But we can guess, because, like, if you think the patient is on, if the patient's right atrial pressure is very high, you can guess that the patient is on the flat portion of the Frank-Starling curve. If the patient has Vexus score 0, you can guess that the patient is in the steep portion of the Frank-Starling curve, so the patient would be fluid responsive. So we can definitely guess, like you do with the inferior vena cava, but other than that, I don't has it has any added value in assessing fluid responsiveness.
Yeah, the question is to determine in several stages the hemodynamic approach with POCUS. So in one way, in one portion, the fluid responsiveness, the fluid tolerance, etc., and make a whole picture.
Yeah, absolutely.
So we have just to finish the questions, we have several congratulations on the chat from David Pascual Roja Flores from Mexico, Edgar Chavez de Mexico también. They say it was an excellent session, excellent conference. They all give you some their regards.
Yep. Thank you so much. Yeah.
So I have to first congratulate you for your excellent masterclass in the name of USPed Latinoamérica, in the name of Javi, who is right there on his car driving, but listening to the conference. So it was an excellent conference to the approach of hemodynamics using Vexus, and we invite you to discuss every time we on Twitter, to be this way, to talk about POCUS and Vexus. One more time, thank you, Dr. Koratala, for your time to be on this Saturday morning, and thank you all who participated and asked questions on this day.
Thank you so much. It's a pleasure to be here and interacting with everyone. Thank you.
Yeah. So we're going to bomb you via Twitter with some things that we discover from Vexus on children. So stay focused, stay on.
Absolutely, happy to learn. Yeah. Thank you.
Thank you. Have an excellent day. Have a great day.
You too. Thank you.
Muchas gracias a todos.